October is National Breast Cancer Awareness Month. We spoke with Dr. Holly Mason, Chief of Breast Surgery at Baystate Medical Center, to get her ideas and advice on some of the best approaches to detecting and, if necessary, surgically dealing with breast tumors.
Well, there's no question that the topic of screening mammograms is very controversial. And a lot of the controversy comes from the uncertainty between all the different societies that make recommendations about when to start screening. I think the most important thing right off the bat to consider is what is an individual woman's risk for breast cancer. Because the controversy really is for women who are at average risk for breast cancer. Someone who has a strong family history or has other things going on with their breast wouldn't be considered average risk, and then we would recommend starting at age 40 and on a yearly to 1 to 2 year basis. But for the average risk woman, that's where all the controversy is. Now, there are some things that can make the ability of the radiologist to read mammograms more difficult, such as the woman with dense breasts. And Massachusetts now has a breast density law to help address that in terms of whether or not if a woman has dense breast tissue, whether or not she should have a discussion about other screening tools for the breast. But, you know, in terms of when to start screening, I think it requires a careful discussion between a patient and her primary care provider, whoever will be ordering the screening mammogram, to discuss not only the pros of having a mammogram in terms of how sensitive it is and how likely it is to pick up an abnormality, but the cons to having a screening mammogram, especially in a woman with dense breasts in terms of false positives and the need to have biopsies. The American College of Radiology recommends starting at age 40. American Society of Breast Surgeons and American Cancer Society recommend starting at age 45. There's no question that even an average risk woman should start at age 50 and have a mammogram at least every 1 to 2 years.
There's been a lot of attention on this area since the Angelina Jolie factor. Yes. A couple of years back when her mother had died of cancer. She was tested, I believe, found genetically positive that she would most likely, if not almost certainly, have cancer later in life. She went for prophylactic, preventive breast surgeries. I gather that's fairly rare, but perhaps as science has developed, becoming a little more common. Would that be fair to say?
Well, she was found to have the BRCA mutation. Her mother had ovarian cancer. And the mutation that she had about an 80% lifetime risk of developing breast cancer and did opt to have both breasts removed to help reduce her risk. The risk when you do that is not, you don't bring it down to zero. That's just not possible, but about a 95 to 98% risk reduction. In patients who have the BRCA mutation, opting to have the double mastectomy isn't that uncommon. Actually, it's fairly common. If someone were to choose not to have the surgery, we would screen them differently. So not only would they have yearly screening mammography, we would also incorporate screening breast MRI. So there are options, and it's a very careful discussion with a patient when they're found to have this mutation.
Let's talk about ultimately what you do, breast surgery. And the minute a woman hears that, for whatever reason, your situation requires surgery, all kinds of thoughts go through the mind. But there are various surgical approaches now. It's not always a radical mastectomy, full removal of the breast or breasts. There are other approaches if the disease is in that situation.
Yep. So we fortunately no longer do radical mastectomies. Those radical mastectomies where you take off the breast, the muscle, and all of the lymph nodes. And really there's no benefit in terms of surviving breast cancer based upon that kind of procedure. So we have really scaled back. And we continue to scale back as we get a better understanding of breast cancer. So mastectomy, where you are removing the breast, remains an option. And oftentimes that can be accompanied by reconstruction or rebuilding of the breast, which is done by a plastic surgeon. But most patients are actually candidates for what we call breast conservation, or you could call that breast preservation, where the woman will keep her breast, will do a lumpectomy, oftentimes followed by radiation. And the important thing whenever I see a patient and I'm discussing the surgical options is no matter what we choose, keeping the breast or a mastectomy, there is no benefit of one over the other in terms of surviving breast cancer. Everything that matters in terms of surviving breast cancer is based on the medical therapy that we receive. So surgery is really keeping things under control in the breast. And if a woman has a small tumor and we feel we can do a lumpectomy without impacting the cosmetic appearance of the breast, that is as safe an option as a mastectomy.
Dr. Holly Mason, breast surgeon specialist, thank you for coming in. Thanks for your time.
Thank you for inviting me.